history is withheld. Excellent. Reticulonodular opacities in the left hemithorax. Good. Along with it, are you seeing anything else? Can you refer to what are these lines are called as? So along with reticulonodular, there is one more finding is there. What are these lines corresponds to? Good. Curly B lines. Excellent. So curly B lines means it is corresponding to interstitial thickening. So you are seeing interstitial thickening. Along with that, you are seeing reticulonodular airspace, reticulonodular opacities bilaterally, but there is no evidence of, in this patient, there is no evidence of cardiomegaly. There is no evidence of pulmonary edema, to call it as like, there is no pleural effusion. There is no cardiomegaly. There is no widening of superior vascular silhouette, superior mediastinal silhouette to suggest the patient is volume overloaded. So this patient comes in, I'm just going to give you some history. Patient comes in with history of weight loss, hemoptysis. What do you think is going on? Heavy smoker. Excellent. That's what the diagnosis. The patient is having. So what you are seeing is nodular, and you can clearly see there is a distinction between the left and right. There is asymmetrical, prominent interlobular septal thickening predominantly on the left as compared. Right is also there, but predominantly on the left. And there is some ill-defined opacities occurring at the level of left AP window and also along the level of left hilum. So this patient subsequently underwent chest CT. You can see there is a nodule along the para-aortic region and then extending all the way as a mass-like opacity into the left hilum. And you can see on the lung window this distinct, prominent interlobular septal thickening on the left side. And also this septal thickening is not smooth. It is nodular as well. You can see there is nodular asymmetrical interlobular septal thickening on the left lung as compared to the right. And there is a mass-like opacity in the hilum, and also it is extending all the way up until the para-aortic region, which corresponds to the X-ray finding of why there is an ill-defined opacity at the level of AP window as well. So this is a patient who has a small cell lung cancer with lymphangitic carcinomatosis. So the point is, always remember, many times people say that lymphangitic carcinomatosis has to be nodular. No, it need not to be. Lymphangitic carcinomatosis can be smooth, it can be bilateral, it can be unilateral, it can be localized. But when you see a mass lesion, if you see interlobular septal thickening, whether it is smooth or nodular, your job is to raise the possibility of lymphangitic carcinomatosis unless and until you are seeing clear signs of volume overload. Remember, in patients with cancer, they can have pleural effusion as well because they have, like, cancer seeding into the pleura, which may be manifest in the form of effusion. You cannot call that as pulmonary edema.